In this chapter, we're going to be looking at drugs for treating reproductive and genitourinary concerns. So some of what we're going to be talking about again or a lot of what we're going to be talking about again is going to be complementing the chapter on the renal and urogenital systems and pathology. So many of the medications, particularly for certain conditions, we've actually already talked about. So we're going to be talking about a lot of medications used to treat infections, but then specifically in this chapter, we're going to be looking at some other things, particularly for reproductive and sexual health within this chapter. So in looking at again, so the two kind of unique drug classes and things we're going to be looking at are going to be dealing with reproductive and sexual health. So for reproductive health, we're going to be looking at different diseases and disorders regarding the reproductive system, and then regarding sexual health, we're going to be addressing things like conception, sexually transmitted infections, and erectile dysfunction. So we're going to be looking at all of the different drugs. Like I said, a lot of the drugs that we're going to be talking about as far and pathologies are going to be drugs. For instance, we're going to be kind of hearkening back to a lot of like antibiotics, for instance, for certain infections regarding the reproductive system. So again, contraception, so we're using it's a deliberate use of a medication or technique in order to prevent pregnancy. As we're going to talk about, and what's going to be important in this discussion is going to be looking at there's many different types of contraceptives, both there's medical contraceptives, there's barrier methods. We're going to be discussing all of those and looking at, again, the effectiveness of them, obviously, in looking at the medications and the pharmacologic interventions regarding that. We're also going to be discussing, what are some concerns that could come up when an individual is taking a contraceptive. So yes, effectiveness based on the method and its correct use, and that's something that I'm going to talk about on the next slide, is that part of the effectiveness comes in the appropriate use of them. So, for instance, just if we're just talking about birth control pills as a group as a whole, the effectiveness is very good. The issue is then again, if people miss doses and things like that and get off the regimen, that's when the effectiveness starts to go down a bit more. So again, oral contraception. So we're going to be talking about this. Again, this is going to be a very common thing athletic trainers encounter, and a lot of individuals are also going to take oral contraceptives, sometimes for things outside of just birth control. So there will be medical conditions where sometimes, and that's something I want you to kind of be on the lookout for. Again, I always suggest that you read the chapters before even listening to these lectures, but hopefully that's something that you've kind of picked up on, is that there's some other applications to those drugs as well. And again, so our role in this, again, as sports medicine professionals, again, you should be able to discuss these issues. Of course, at some point, again, there's other primary care providers that should be involved in this process. So, but again, you should be able to, properly educate your patients in instances where, obviously the prescriptions and stuff need to be filled. That's going to be the responsibility of other individuals. So this is a graphic taken from the text, and here we're just basically looking at the effectiveness of various contraceptives in basically decreasing order. So if we're looking at this, so we're seeing up here fewer pregnancies. We see the various options up here, and even you could kind of even like circle this whole group here as definitely being probably your more effective techniques. Obviously, abstinence is very effective because you're not engaging in sexual intercourse. But then, beyond that, you still have many different options that are very effective. Now, again, a lot of the effectiveness, again, is based upon, appropriate use. So, sometimes, as I, brought up on the last slide, there's user error, if you will, that causes these to be less effective and sometimes can be, can be obviously then will allow for pregnancy to take place. But this just kind of shows you the general effectiveness. Now we're going to talk about the different classes of medication. So again, and this is all in the learning objective. So again, being aware of like the different types of birth control medications. Again, the effect, how they work, what are some of the side effects. Those are going to be the things that you're going to want to kind of complement in your notes, what we want to make sure that we're aware of for the exam. So if we're just to look at the different classification of contraceptive methods. So again, we're looking at different types of birth control. We're looking to prevent pregnancy. And again, there will be other applications to these. So you'll sometimes hear of, a woman being on these contraceptives for other medical reasons. So there's short-acting hormonal contraceptives. There's when we're looking at those. So again, that's your oral contraceptives. There's different patches and then contraceptive vaginal rings. So the other thing we're looking at with a lot of these contraceptives is that we're also looking at hormone-containing contraceptives and non-hormonal containing contraceptives. And the one thing you're going to see is that the hormonal contraceptives actually are going to be the ones that typically are going to have more adverse effects, potentially, more so than the non-hormonal contraceptives. So we're going to be looking at a lot of those and seeing kind of the different side effects that you have or adverse effects that are potential there. Then you have the long-acting reversible contraceptives. So that's going to be your hormone injections, IUD devices with or without hormones, and again, various other implants. Then you have of course, your barrier methods. So things like the contraceptive sponge, diaphragms, condoms, and spermicides. Those will be your barrier methods. Obviously, there you're really, you're not looking at, typically any type of, again, hormones in those cases. These are literally things that are just that they're barriers to the implantation in pregnancy. And then you have your emergency contraceptions, which would occur. Obviously, someone would take this, after intercourse, or if there's a situation where they were not taking birth control and they were looking to prevent pregnancy. So your short-acting hormonal contraceptives. So again, we're just starting with our classifications and talking about them all sort of individually. So, again, as I said, the hormone-containing contraceptive. So again, that's another way you could kind of sort of look at these and separate them, if you will, to maybe make it a little easier to kind of get the start with. So the hormone-containing contraceptives are obviously going to have more side effects than the non-hormonal. Okay. And typically when you look at the hormone-containing contraceptives, they're going to contain if they're a combination, for instance, they're going to contain estrogen and progestin. And we're going to talk about some that are only going to contain one or the other. So that's something to be aware of when you're looking at these. So again, for the most part, and again, I'm saying adverse effects. Again, many individuals use them and never have any problems, just like a lot of other medications we discussed. But it's important to be aware of, so that again, the person has kind of all their information and decide, what things they're, willing to risk, given even a small chance of it happening. So if we look at, again, the combination oral contraceptives are going to contain some combination of estrogen and progestin. So again, the idea is that they're going to inhibit gonadotrophin releasing hormone, which is going to prevent ovulation stimulation. So that's essentially what you're looking to do by taking those particular medications. The other thing you're looking at, again, it's going to cause endometrium thinning, which is going to prevent a fertilized egg from implanting. and also a thickening of the cervical mucus. So there's different physiologic things that are going to occur with these medications. These are some of them that are going to basically be looking to inhibit pregnancy. And again, different mixtures and active ingredients and the extent to which it's going to impact the menstrual cycle. So there's different ways in which that the menstrual cycle can be impacted with these. Most of your combination oral contraceptives are going to contain about 10 to 35 micrograms of ethinyl estradiol. High doses, you're going to have 50 micrograms of estrogen in some of those combination products. So this would be something to make note of as far as the ingredients in these. Again, high-low doses seem to have similar profiles regarding pregnancy rate. So there doesn't seem to be a difference. So many times the low dose oral contraceptives are sometimes preferred just because they tend to be equally as effective, and they tend to have fewer adverse effects. The only difference is that sometimes there does tend to be a higher incidence of irregular vaginal bleeding within the first few months of use. Okay, so that's something that can be noted as far as looking at the differences between high and low dose oral contraceptives. And there's also what they call the progestin only pill, or what they call the mini pill. Again, so here's another situation where you have a lower dose, which can be pretty much, as we said, pretty much equally as effective. And again, a less chance of with fewer side effects. So the progestin only mini pill is one that does tend to be very effective, and again is popular because of the less risk of negative side effects that you get from the higher dose medications. It should be noted that one of the more, again, the most common, like again, the mini pill, norethindrone is the name of the mini pill. It goes by the name Camela. There's other trade names, if you will, but those are the ones that could be noted. And again, for the most part, the only thing that the lower dose pills like these tend to kind of cause when you're talking about the progestin only pill is that there tends to be, and you see this with a lot of lower dose pills, they cause more what they call breakthrough bleeding or spotting, more so than with the higher dose. Pregnancy rates with perfect and typical use, though, of the lower dose or the progestin only pill tends to be very similar to the use of the more classic combination pills, where the doses of the hormones are much higher. So if we look at the advantages and adverse effects regarding the oral contraceptive, so there are health benefits to them, and as I said, there's many sort of, again, non-birth control related applications to these. So there are some advantages potentially. So there is a decreased risk of certain cancers and tumors. They also can help with menstrual dysfunction. So sometimes people will take them because of menstrual dysfunctions. There's also the prevention and treatment of like ovarian cysts. The other benefits, there's osteoporosis prevention, iron deficiency anemia. The ectopic pregnancies in individuals tend to happen at a much lower rate in individuals who do take oral contraceptives as well. So those are just some of the, again, other health benefits. Obviously, if someone's taking it for the purposes of preventing pregnancy, again, when taking appropriate, that's obviously the reason why you're taking it and why that would be an advantage for that individual. But these other things are very important to be mindful as well when we're looking at these. And again, some individuals may be taking them again for those other, even for those other purposes. However, again, there are risks, much like everything else. So, one in particular that you have to be, sort of mindful of, if someone is a smoker older than age 35, there is significant cardiac risks associated with it, and that should be something that an individual should be made aware of. So if they're smoking and they want to take birth control, they should really consider quitting, although they should probably consider quitting for other reasons as well, because the negative effects of smoking. And again, there's assorted serious and common side effects. So again, there's more serious things like the blood clots, heart attack, stroke. So the cardiovascular risks are probably some of the more serious ones. Again, they're reduced significantly if someone's not a smoker. Whereas there's less serious risks, or some adverse effects. For instance, like stomach pain, headaches, swelling or pain in the legs. Now, if there's swelling or pain in the legs, if there's blood clots, you have to be mindful of that. Obviously, that's a more serious thing. There's various types of abdominal cramping and bloating, dizziness, weight gain, breast pain, nausea and vomiting. So there's a list of all of these in your book. So some of these I've mentioned, you may want to add those into your notes as well, kind of as you're kind of going through and looking at those. They're not recommended that individuals take them, again, if they're with various comorbidities. So again, women who've had certain types of cancer may be at higher risk for various clotting disorders or strokes. There's also the potential for liver disease, severe headaches. If a female has some of those comorbidities, they should, again, it's probably not going to be recommended that they utilize an oral contraceptive. And there is a sufficient correlation. There is an association between oral contraceptive use and the subsequent risk of breast cancer. So there has been shown that, through a review panel, that there was a sufficient evidence for an association between oral contraceptive use and breast cancer risk. Again, there have been some inconsistent results with women who have previously used them versus those who have never used. But again, the increased risk was primarily noted for women who were current or recurrent oral contraceptive users, and those who were less than 35 years of age at diagnosis. So just kind of know that there is a correlation. Again, it's always something that does get discussed, the risks associated, just as you would with any medication. Now, there is something that, and this is kind of a sidebar discussion. So, we look at, can oral contraceptives be used as a performance enhancing drug? So in other words, is there an anabolic component to estrogen or progesterone when we're looking at this? So in other words, can they be a performance enhancing drug? It has been suggested that they may have or I'm sorry, I misspoke. Progesterone, does progesterone have a catabolic effect? So basically, they've kind of studied this. There doesn't seem to be in individuals with or without or not taking an oral contraceptive, there doesn't really seem to be a big difference as far as performance related to various tests of strength or power related activities. So there's little to no evidence that these hormone fluctuations with these particular hormones is going to influence anaerobic power or just general anaerobic performance. So there was I guess a slight increase when you look at oxygen consumption, but when we're looking at any type of anaerobic performance, there doesn't appear to be, again, any particular benefit. And again, what I'm just going to suggest is, again, kind of look at that other list for the adverse side effects. Again, obviously some side effects are going to be a little bit more serious, if you will, than others. But again, for the most part, it's good to be aware of all of these, just in case you do get say you get a patient who's recently just maybe started an oral contraceptive and they're having issues, to kind of note whether something's a little bit more serious and needs attention, or if it's just going to be kind of a adverse effect, and it may cause the person to potentially have to change the type of oral contraceptive that they're taking. So other short-acting contraceptives, so you have the contraceptive patch and the vaginal ring. So first, talking about the patch. So the patch, again, is going to be, again, a combination of hormones used to stop ovulation. So these are going to be transdermal patches that basically are applied. Norelestromin is going to be one of them that gets utilized. Ethinyl estradiol is another one that will be utilized as well. Again, they're going to have, typically two hormones are going to have both estrogen and progestin in them. And again, similar to kind of what we talked about before, they're going to be able to stop ovulation. Again, they're going to stop the ovaries from releasing the eggs, and it's going to cause that thickening in the cervical mucus that's going to keep the sperm from getting to the egg. One thing to note, particularly with norelgestromin, is that there's an FDA black box warning for venous thromboembolism. So that's probably one of the more significant things that you have to be aware of. And again, the patient should have an appropriate discussion, knowing that that could be a potential risk. Then you have the vaginal ring. The idea behind the vaginal ring, and the vaginal ring is going to contain ethinyl estradiol and etonogestrel. This is known as the Nuva ring. They're currently available. It's basically a flexible, soft implant that gets put in, and each ring basically releases a certain amount of estrogen and progestin daily, and then those hormones get absorbed through the vaginal epithelium. When a vaginal ring gets used, the hormone concentrations are usually kept relatively constant, and then they basically leave the ring in place for 3 weeks, and then it gets removed for 1 week to allow for what they call withdrawal bleeding when we're doing that. So again, it's going to have that significant release of estrogen and progestin. Again, things that need to be looked at when you're dealing with these. Again, black box warning. Again, women who are older than 35 and smoke cigarettes. Again, that's where you're going to have your significant cardiovascular risk factors. So that's probably the biggest thing that we look at with this. As far as the efficacy and adverse effects, vaginal rings are very similar to those with oral contraceptives. The adherence tends to be better than the pills, just because basically the user inserts the ring once a month, and that's it. They don't have to take the pills every day, and that kind of tends to be the compliance and the potential errors tends to be a lot less with it. Okay, so looking at some long-acting reversible contraception. So we went through all the short-acting. Again, some of the mechanism of action here is going to be a little bit longer. Again, start with your knowing what types kind of fall underneath this. So again, these are available for several years, but they can either be removed or basically discontinued, and the person would then be able to get pregnant. So the first one is going to be, again, a contraceptive hormone injection. So again, be aware of some different examples of these. So again, an example here would be what we call the Depo-Provera, or you hear people saying they got a Depo shot. So Depo-Provera or Depo-medroxyprogesterone acetate is another name. This basically is going to get administered every 3 months. And that's going to then allow for a prolonged action of birth control at that point. One of the more common things that an individual will experience with this is amenorrhea. So that is something that is commonly experienced. Again, there are others. So for all of these, I'm going to kind of name some ones that stand out. But again, just be aware of all of the potential adverse effects that are going to be associated with these. But a lot of women end up having irregular vaginal bleeding, amenorrhea, seen very common with this. The black box warning, and again, these are obviously fairly relevant. An individual may lose significant bone density when taking this injection. Another note with this, actually, before I move on to the next thing, I just thought about this. So, you know, when an individual begins this, they get contraceptive hormonal levels usually as early as 24 hours after the injection, and it's going to be maintained for greater than or equal to at least 14 weeks. Most of the levels are effective for up to 16 weeks. Now, as far as, like, again, if a person then decides that they do, they no longer want to be on, no longer have the birth control, they have the option of stopping the injection. Now, because of its duration of action, ovulation might be delayed for up to 18 months after the last injection. So you just have to kind of, understand that if you stop, it's going to take a little while. Usually, once ovulation does then occur, fertility is pretty rapidly restored then at that point. So the subdermal contraceptive implant is another option. So, and these are going to be progestin based. So they're progestin-only subdural implants, and these are another long-acting type. Etonogestrel is going to be a common implant used. Nexplanon is the trade name for it. So this is going to be an implant that gets put in. So it gets put in subdermally, usually right around the medial epicondyle. So, where they put it in there is basically they're looking to obviously avoid any of the blood vessels or nerves within that area. But that's usually where they'll place it. Again, it's going to be a very slow release. So, like I said, 50 micrograms a day is not a lot. And basically, it's released for up to 3 years in an individual. So again, it's going to be released at a rate of about 50 micrograms per day, and that's going to, again, for up to 3 years it can be utilized for. Most of the adverse effects with this are going to be very similar to what other individuals experience with progestin-only birth control. So if you look at that, that's going to be what most of your risks, so very similar to what you get with the progestin-only, oral birth control and other forms. And then the other long-acting is the intrauterine device. So if you look, there's a picture in your textbook that does kind of show how an IUD is implanted in the uterus. And depending on the type, they could be good for as little as 3 or up to 10 years. So the copper-bearing type are the ones that do tend to, that last longer. So out of a copper-bearing IUD, that can go up to 10 years. And, again, it's effective for up to that point. Paragard is a common copper-based intrauterine device. Again, the idea here is it just prevents implantation of the egg. And then you have the levonorgestrel releasing IUD, also known as Skyla or Mirena. That one has the shorter time span. So that one can be used for about 3 to 5 years. Vaginal bleeding is usually going to stop with that one after about a year of insertion. So, again, some individuals that, depending upon the specific type, that's where the 3 to 5 year comes in. But that one's going to be slightly different. Again, in both instances, you're preventing that implantation of the egg. So now looking at barrier methods. So barrier methods just essentially prevent sperm from even entering the uterus. So you're going to have ones that are literally a barrier device that block the sperm from entering, or you're going to have some that actually contain what's called a spermicide. Okay, so spermicides, and you actually see this, spermicides themselves are just, they actually sell this in just basically like a foam. that a female can use, and that basically damages the sperm cell membranes to prevent fertilization. So this is just a foam that gets inserted into the basically into the woman's reproductive tract. And then you have the contraceptive sponge, which is a little soft disc-shaped foam that also contains spermicide. So you can just do the spermicide by itself, or in the case of the sponge, it's basically just like a little soft foam disc that can be inserted. It acts as both a barrier device and a spermicidal agent. There are some side effects that could potentially come along with the sponge. So again, the more, you could have vaginal irritation or dryness. You're at risk for infection. And obviously, there's still a risk of contracting sexually transmitted infections. So, a condom is also a barrier method, but a condom actually reduces the chance of many types of sexually transmitted infections. The sponge doesn't do that. The sponge just looks to permit or to prevent pregnancy. There's also something called toxic shock syndrome, which is a major red flag. So make sure to note the signs and symptoms of toxic shock syndrome. That's also something that it actually also comes with a warning when women use tampons as well. So, toxic shock syndrome is basically an infection that can really escalate very rapidly. So there's specific signs and symptoms that commonly go along with that. So just note your signs and symptoms of toxic shock syndromes. You should be able to recognize that in the case that an individual is coming down with toxic shock. So emergency contraception, again, this is going to be after an individual has intercourse. As far as what most people refer to this as the morning after pill. And so an individual could take this as a pill in pill form. An individual can also insert a copper-bearing IUD after unprotected sex to prevent pregnancy. So emergency contraception can prevent many types. So it can prevent up to 95% of pregnancies. This to be taken within the first 5 days. So for it to be effective, again, you obviously want it as soon as possible, but within 5 days, it's still fairly effective. So the most of these now are available as well over the counter. So again, they're also going to have potential negative effects as well. So it is something you do have to be mindful of. So it is also important to note that an established pregnancy cannot be interrupted with emergency contraception. So again, it has to be within the first 5 days, whether that's the pill or an individual inserts a copper-bearing IUD. So turning to infections, so sexually transmitted infections. So again, a lot of what you're looking at here is determining which ones are bacterial and viral. Most of these already we've discussed in the pathology portion of the class. So again, that's kind of breaking that up as well. So again, understanding which ones are bacterial, which ones are going to be viral, because that's obviously going to tell you how they're treated medically as far as that, because obviously your bacterial infections are going to be treated with antibiotics. Your viral infections, you're going to have to take an antiviral medication. So bacterial infection and treatment, so chlamydia, and what you're going to see here is, and I'm not going to go through each one, we've actually talked about all of the different types of antibiotics. So again, you're going to see different types of antibiotics are kind of connected with certain bacterial sexually transmitted infections. So chlamydia, you have pelvic inflammatory disease, gonorrhea, syphilis, and trichomoniasis. So that kind of tells you your different types of bacterial infections and how those individual ones would basically be treated. So these are all the different classifications of the different types of bacterial infections and kind of what you would use. So for instance, again, chlamydia, azithromycin, erythromycin, doxycycline, those are ones that the medication options. So again, it depends upon the type of bacteria. So you should be aware of all the signs and symptoms of these as well. There's a table in your textbook that kind of covers that. And like I said, we kind of go through these a little bit more extensively in the pathology section as well. You have your viral infections in treatment. So human papillomavirus. So this is basically, individual gets your genital wart. So there's vaccines available for that. That's probably the best medical option to prevent the HPV infection. Herpes simplex virus. Your options for that are going to be your antivirals. Now, the things to remember is that individuals, once they have contracted herpes simplex virus, there's always the chance that it could reoccur. So that infection, pretty much once you've had it, there's always a chance it could come back. So many times individuals will just repeatedly take antivirals here, so you could recognize the different types of antivirals that are listed here. Acyclovir is probably the one that does get prescribed the most typically for that particular infection. And then human immunodeficiency virus, which we talked about. So this particular virus ends up basically suppressing the immune system. And usually what they do is a cocktail of a combination of drugs that is used to suppress HIV replication. As we all know, the idea is over time, once T cell levels reach a certain level, that's when an individual then has AIDS or acquired immunodeficiency syndrome. But what the cocktail tends to do is basically suppress it. What that does is it basically keeps the person HIV positive, but it kind of delays an individual progressing to AIDS. So now we're going to look at some other reproductive urogenital concerns, both with men and women. Again, really important, part of our role as a health educator, just regarding a lot of these very common concerns that, we could possibly run into. So we've already kind of talked about, various sexually transmitted infections. Again, for women, we're looking at things like menstrual dysfunction, urinary tract infection, osteoporosis, kidney stones, which are fairly common in men. You look at erectile dysfunction in kidney stones. So when we look at urinary tract infection, usually that's caused from an E. coli bacteria that usually is going to come from the urethra and anus. So it's a bacterial infection typically that we look at. Again, the urinary tract spans the kidneys to the urethral meatus. And again, it's normally sterile and resistant to bacterial colonization, but sometimes, there could be contamination at the distal urethra. Again, so this could be an issue as far as developing, some potential other issues in and around the urogenital area. So again, usually the first line of treatment is Bactrim or Septra, which is a first line. You may need an analgesic. So many times there's a lot of discomfort associated with urinary tract infections. Women do tend to be at greater risk for developing urinary tract infections just because they have such a short distance between the urethra and both the anus and urethral opening to the bladder. So just anatomically, it's much more common in women. Usually infection limited to the bladder can just be it could be painful and annoying. However, you could end up having it spread to the kidneys and cause a kidney infection, or what they call acute pyelonephritis. So that's something that could happen as well. Many times other antibiotics can be used. Again, Bactrim and Septra tend to be some of the ones they use. Sometimes they may use ciprofloxacin or Cipro for treating these. Nitrofurantoin is another one that can also be used. So Macrodatin or Macrobid, or some other ones that your book mentions as far as treating urinary tract infections. And again, they may need something because of the difficulty with urination that comes along with it. They may need some pain medications as well. Osteoporosis, which is basically bone deterioration with low bone mass, and osteopenia, which is just an abnormal bone density. So it's not as basically it's a continuum of the disorder. So osteopenia is when there's just that initial loss in bone mass, osteoporosis. It's basically when an individual's bone mass basically reaches a certain level below a certain standard deviation of the norm. That's when you're going to be looking at then a person being diagnosed with osteoporosis. And again, there's various things when you look at osteoporosis. Again, generally people are asymptomatic until they get like maybe like a fracture from a sudden fall. They may also prevent with like, back pain, loss in height, different spinal deformities could kind of come about as well along the way. As far as like your early treatment are some simple things that can address osteoporosis and osteopenia. Initial supplementation with vitamin D and calcium. Many times individuals, particularly in the Northeast, are deficient in vitamin D. So that's something that commonly can be supplemented with. And obviously then the calcium supplements could come along with that. Now beyond that, prescription-wise, bisphosphonates are things that can be utilized. So there's things like Fosfomax and Prolia that can be used, and what they basically are anti-resorptive medications that basically slow down osteoclast breakdown. So osteoclasts are those cells that break down bone. So bisphosphonates basically slow the activity of those down in order to help strengthen the bone. And again, so know both names. So Fosfomax is the trade name for alendronate, and Prolia is the trade name for denosumab. So those are two different types of medications that you look at for that. And then there's what are called osteoanabolics, which stimulate bone growth. Teriparatide or Forteo is probably the most, the common one that you see. And basically what they do is they force this like basically rapid increase in bone formation and remodeling. And the idea is to help improve the bone microarchitecture. So that's something to be aware of. So teriparatide is actually the only osteoanabolic medicine to be approved to treat osteoporotic men. So that's something interesting to know. And it's important that teriparatide needs to be supplemented with vitamin D. So that's something important to note about that particular medication because it actually causes a decrease in vitamin D synthesis. So you should be probably supplementing with vitamin D in order to do that. So there's been other medications as well. So there's off-label application of medications to treat osteoporosis and to treat bone marrow edema. So there are some other medications used for that, but these are your primary medications that we look at for dealing with osteoporosis and osteopenia. So looking at some other conditions here, and again, some of these were talked about in the pathology chapter. So endometriosis is when you have your uterine lining tissue going into the pelvic organs. So this is where you'll see some of the tissue kind of get into the ovaries and fallopian tubes. And then the issue is that, outside of the uterus, that tissue then will thicken and bleed just as kind of like the normal tissue does. However, in those other areas, it's going to cause other problems. I don't believe the pathology chapter talks about endometritis. That's basically just an inflammation of the uterine lining, usually from an infection. Now, this is usually just a shorter term condition that's a little bit easier to treat. Again, there's, your specific symptoms related to both of these, again, depending upon the extent to which the endometriotic tissue is kind of affected. Now, as far as treatment regarding like endometriosis, there can be potential surgical resection potentially, and there's also drugs that can be used. So, your treatment options regarding endometriosis, endometritis, hormonal contraceptives. So again, there's various types of birth control pills that can be utilized. Norethindrone is one. They also can use some of the injections. Medroxyprogesterone is one, and then some of the patches and rings can help slow the progression of the disease. NSAIDs, nonsteroidal anti-inflammatory drugs like ibuprofen, can be used for some of the Can be used with contraceptives for some of the pain. They could possibly utilize gonadotrophin releasing hormone, which will suppress estrogen release by the ovaries. And then for some individuals, even they have found that cannabis can be used for some of the pain associated with endometriosis. We also talked about kidney stones, so renal lithiasis or nephrolithiasis, where these hard deposits or calculi, where the kidney stones, basically the minerals and salts, form into a little stone inside the urine flow, and it blocks urine flow. It can cause a lot, very uncomfortable, even very small kidney stones are very painful. To get, in general, over-the-counter medications and analgesics is needed. One of the things you may see is blood in the urine. Again, sometimes you won't actually be able to see the blood with a urinalysis. They'll sometimes be able to see red blood cells in the urine. Typically, an individual may need some stronger pain meds as the kidney stone passes. However, if it's much larger, there may need to be further intervention that's kind of dealt with in order to get rid of the kidney stone. For erectile dysfunction, so there's various causes of erectile dysfunction. Again, one of the potential issues could be atherosclerosis of the arteries in the penis, which will limit blood flow. Diabetic neuropathy and surgical injury are also other things that can cause erectile dysfunction. So, and again, you usually will see a lot of artery issues in individuals who smoke and have diabetes. So your most common medication utilized to treat this is phosphodiesterase PDE5 inhibitors. Again, they're going to be very good. Basically, what they do is they allow for the arteries to dilate. They tend to be less effective with neurological problems. Testosterone enhanced can also increase desire, but does not resolve erectile dysfunction. So sometimes individuals who, if they do hormone replacement therapy, that won't necessarily improve ED. So some individuals, may end up doing both. Again, this will be particular. The PDE5 inhibitors will be particularly useful as it relates to allowing for normal erections to occur. There's multiple adverse effects that could be potentially an issue here. So for cardiac patients, they're usually going to be contraindicated because many of the issues for cardiac individuals are concerned. There's issues with blood pressure. Obviously, priapism is the one you probably hear of the most. That's a prolonged erection, which could cause actual damage to the blood vessels in the penis, so that's important to be aware of. There's other more minor things like headaches and things like that could sometimes be an issue when an individual first begins taking them. And again, typically, lower blood pressure, cardiac arrhythmias are things that people need to be aware of. And now this is kind of an interesting one. So in the textbook, they talk about how PDE5 inhibitors will not enhance athletic performance. So it was thought of, particularly for weight training, that you could increase the pump in your muscles, just because of, there's the presumption that the nitrous oxide element of ED medications will be beneficial for that. So from 2006 to 2008, they looked in that, and they didn't really see things with that as a performance-enhancing drug. So basically, right now, we don't know for sure. Now, there has been some talk more recently. They've further looked at this. But as far as we're concerned in class, the only benefit that has been experienced is there's a minor experience in athletes in endurance sports. So far, that's all we definitively know. However, they are starting to look back at it for some other things. And interestingly enough, they're actually looking at a lot of the PDE5 inhibitors in relation to prevention of cardiovascular issues. So now if somebody's already been diagnosed with a cardiac issue, they usually don't get prescribed for them or they're watched very closely, but there is some potential for application there as far as a preventative measure. So again, make sure, again, just kind of look at some of those, particular drugs, sildenafil, Viagra, Cialis, also known as tadalafil. So those are some examples. I believe the textbook at least mentions two others. So again, make sure you're aware and be able to recognize those. So in summary, again, be familiar with pharmacological inventions for a lot of these reproductive health concerns. Again, start with the classifications, kind of know, for instance, regarding contraceptive, short-term, long-term, kind of how where all of the different medications fall. Again, you could always refer individuals if need be, but again, your job is to assist with educating. And again, there's various antibiotic options if an individual is showing signs and symptoms of various types of infections. Also be aware of some of the sexually transmitted infections are also viral, so they'll need an antiviral drug. And these are your learning objectives.